I think we can let the last few people trickle in. Thank you all for coming today. We have a really great presentation set up for you. I'm Jasdeep. I'm one of the fourth year residents and chiefs, and I'm very pleased to introduce our speaker today, who's Dr. Rupi Legha. She is a cisgender daughter of Punjabi Sikh immigrants who currently resides in Los Angeles, California on stolen Tongva land. Her proudest title is auntie to her beloved sibling Gavin. Nibbling Gavin. In 2021, she established her own corporation to guide her anti-racist clinical, educational, consultative, and speaking endeavors. Some of her recent papers include Nurturing Children's Mental Health, Body and Soul, Confronting American Child Psychiatry's Racist Past to Reimagine Its Anti-Racist Future, which recently went to print. Also the paper, The Color of Child Protection, Anti-Racism and Abolition in Child Mental Health, which is currently in press, and the paper, Getting Our Knees Off Black People's Necks, An Anti-Racist Approach to Medical Care. She is the co-founder of the Anti-Racist Healing Collaborative, home of the Anti-Racism in Medicine curriculum series, which was recently featured in an AMA Journal of Medical Ethics article that she co-authored. She created the Anti-Racism and Mental Health module currently being piloted with medical students at UCSD. She was honored to speak about this exciting new anti-racism curriculum at AACAP's 2021's Fall Assembly meeting. She graduated from Harvard Medical School with honors and completed her adult psychiatry residency training at the University of Colorado, where she participated in the APA Minority Fellowship Program and also spent 3 years working for Global Health nonprofit partners in health in rural Haiti. And then she completed her fellowship training at UCLA, where she was also a Laughlin Fellow. Very pleased to have Dr. Legha here today to talk to us, and hopefully you guys can all stay through the presentation. Thank you so much, Dr. Legha, and I'll let you take it away.
Thank you, Jasdeep, for that really warm introduction. I truly appreciate it. Before I get started, I just wanted to make sure that people have a full view of my slides. Awesome. Okay. Well, thank you so much for inviting me to be here today. I'm honored to have the opportunity to, with you, challenge the racism and white supremacy shaping many of our professional actions. The lives and deaths of Micaiah Bryant, Daniel Prude, and Walter Wallace issue our call to action to integrate anti-racism into our clinical and supervision practices. Their deaths are all the evidence base that we need. So too often our professional imperatives are driven by what historian Christina Sharp calls, quote, the violence of abstraction, specifically statistics, research, epidemiological findings, and numbers. The Say Her Name campaign, launched by Kimberly Crenshaw's African American Policy Forum, brings to the forefront the lives of the siblings, children, grandchildren, and parents brutalized and killed by racism and white supremacy. I'd like for everyone to repeat their names after me. You can do it on mute or unmute yourself. Corinne Gaines, India Kager, Charlena Lyles. We humbly say your names today to ensure we answer the imperative, the call to anti-racist action your murders and our oath require. So trainees and medical students, the next generation of healthcare providers, are leading demands for racial justice and emphasizing anti-racism in healthcare, which calls for more than just the absence of racism. Each of these rich, vast frameworks warrants its own lecture at a minimum, but I did want to at least honor the need to root our anti-racist efforts in bold and radical frameworks like these. Our key guiding frameworks must be critical race theory, abolition, and decolonization. Look them up and read more about them. They are part of the required anti-racist lexicon. Critical race theory in particular aligns with the social justice era we find ourselves in, captured in this photo from June 2020 in Los Angeles after George Floyd's lynching. If we think about our existing medical approaches to racism, like cultural humility or health disparities or social determinants of health, while not without value, we must ask ourselves, Do they give us the language to engage in anti-racist activism, or do they allow us to sit complacent on the racist sidelines? Critical race theory is a guiding framework for this anti-racist supervision approach for many reasons. It frames anti-racist supervision as a mandated response to a public health imperative, not a political choice that supervisors can elect to refuse. It embodies a clear departure from the existing medical educational approaches to racism I mentioned before, like health disparities and cultural humility. They fail to connect contemporary inequities to centuries of white supremacist violence. By emphasizing racism and whiteness's ordinariness and ubiquity in all American institutions by contrast, critical race theory compels us as mental health providers to engage in the clinical and supervisory activism that this approach codifies. CRT also reinforces a dichotomous approach, which I'm going to talk about more later, whereby supervisors either remain on the racist sidelines or engage in anti-racism immediately. Finally, CRT highlights the myriad forms of oppression intersecting with racism, like cissexism, ableism, and classism, and compounding inequality. It therefore justifies this framework's emphasis on heightening critical consciousness to prepare for simultaneously challenging racism and all other intersecting forms of oppression. CRT also emphasizes a critically reflective approach to anti-racism, which leads us to how we begin this work. When engaging in anti-oppression work, citing my professional accolades rooted in privilege and power is less important than reporting my positionality. Positionality refers to how differences in social position and power shape identities and access in society. Whenever I give talks on anti-racism, I share the honorarium that I received. I believe that the audience has a right to know, and I also want other people of color to have a sense of what we can ask for when we engage in this anti-racism labor that's so liberating but also taxing for us. Today, the only institution that I'm representing is my personal S Corp, no other academic institution. And as a cis-het woman and daughter of Punjabi Sikh immigrants, I want to say that I do not carry the intergenerational trauma of slavery, Jim Crow, and settler colonialism. But as a melanated woman engaging in anti-racism work, I certainly know the scars and wounds that training in academia wreak, given their rooting in whiteness and white supremacy. I hope everyone can walk away today reflecting more, not only on your own positionality, but also the positionality of the people around you and to your left and to your right. What are the axes of power, privilege, and oppression that collide during our team meetings, our one-on-one conversations between a resident and an attending, our journal clubs, and our clinical rounds? Is that a question we even ask ourselves? We must. By the time you leave today, hopefully you will be able to provide at least one reason why an anti-racist approach to supervision is different from a not racist approach. Hopefully you will be able to list at least 3 of the 6 action steps we covered today, foundational for anti-racism and supervision. Finally, you should be able to provide at least one statement regarding your positionality as a supervisor and as a clinician. So whenever I come into a new group, it's always exciting and fun to have people chatting and reflecting a bit. I'd love for people to respond to some of these questions by dropping comments in the chat. You're also welcome to take yourself off of mute and speak up. I think the more that we engage, the more engaging, compelling, and enjoyable this experience is. So some of the questions here are, is anti-racism similar to or different from diversity and inclusion? How? Is anti-racism similar to or different from cultural humility, and how? And is anti-racism similar to or different from social determinants of health, and how? So feel free to drop comments in the chat, and if anyone wants to speak up, that would be great too. You can also quietly reflect to yourself.
I don't have like a perfect understanding of the difference, but I would say that like when I think of diversity and inclusion, I think of creating changes to existing structures, but not necessarily identifying maybe past injustices that have taken place. When I think of anti-racism as a curriculum, I think about looking at past and historical contexts, in our case, like within psychiatry or just within medical care, and then thinking about what we can do to structurally make changes to make sure that similar types of mistakes aren't made in the future. Whereas diversity inclusion, you're also doing something in the same vein, but you're maybe not addressing the exact specific nature of injustices of the past. That's kind of how I at least conceptualized it too.
That's great, Justine. Thank you so much for sharing that. So many of our existing approaches are ahistorical. If we think about the last few years, terms like reparations are increasingly part of our shared common dialogue. It's coming up politically, it's coming up in the news, and even in academic medical centers too, and in journal publications. So absolutely, which concepts root us in history, which concepts completely erase it. I'm also seeing a comment in the chat here that I'm going to share with everyone from Abhilash. I have white friends and family and patients, and I offend them when I use the words you are using. They feel deeply hurt. They are all good people, and I look up to many of them. Yeah, so I hear this loud and clear. This reminds me of a talk that I gave in the fall in which I focused on this task of dismantling whiteness as a structure or as a system of oppression. And some of the feedback that I got was that I was white shaming people. So I think this is a great opportunity to think about distinguishing between whiteness as a system of oppression and being white, which is a social identity based on phenotypical experience. So whiteness as a system of oppression and trying to dismantle it is different from pointing fingers of blame at individual people. Any other thoughts or comments that are coming up? These are great.
Being an old white man, having grown up in a galaxy long ago and far away, it causes an awful lot of very deep reflection about numerous events in life, and it is uncomfortable. I'm not going to be shamed by it, but it does create some discord from wanting to be a good person versus who I've been enculturated to be.
Yeah, that's great. Thank you so much for sharing that. So many of us will say when you're in that space of discomfort, that's really the growth and transformation zone. If we think about feeling kind of content and complacent, that's pretty status quo. But when things start to shift or feel unusual or uncomfortable or even upsetting and painful, it probably means we're starting to get to the root of something that we need to be confronting. And many of us know this as mental health providers who provide therapy to our patients. Any other comments?
So honestly, I agree with everything you say, but if I use some of the words you're using, I've lost them. There is no more conversation. Just for you, I have to use some other words.
Absolutely. No, I hear this loud and clear, and this is reminding me of conversations that I've had with my own friends and community. And I think I sort of have a, if we think of anti-racism as being a lifelong journey and being a daily opportunity for growth, I can think back to conversations that I had with people 5 or 10 years ago where I felt a very, aggressive and at times hostile backlash to what I was saying. And now I can sort of see where people are at now, and it's shifted and changed. So yes, sitting with the emotional reactions that we have from people getting upset with us, it's deeply painful for us, especially if we're people of color. And yet this is the work of growth and change. Thank you all so much for speaking up. Let's keep going. Okay, so this approach that we're talking about today stands on the shoulders of giants. For decades, scholars of color have articulated the significance that race, racism, whiteness, racial identity development, and racial trauma in therapy and supervision play. If you do a PubMed search or a PsycNet search, you will find hundreds of articles about these topics. However, Kendi's dichotomy leverages this scholarship in a different way. It conceptualizes anti-racism as a very active process of identifying and challenging racism by changing attitudes, policies, and practices, organizational structures, and systems with the goal of redistributing power in an equitable way. Kendi's dichotomy of all actions is either racist or anti-racist conveys the immediate and urgent imperative for supervisors to choose whether or not they are part of the racist problem or part of the anti-racist solution. Remaining on the sidelines is not an option because the claim of not racist neutrality is actually a mask for racism. This is Kendi's dichotomy, and the question that we can ask ourselves is, which one do we choose? So these are the 6 steps that we are going to cover right now. Let's go ahead and get started with the first one, looking at the historical legacy of racism. So history illuminates how race, a socio-political rather than a biological construction, is what Ta-Nehisi Coates calls the child of racism, not the father. So race is the child of racism, not the father. History also illustrates how healthcare has been no different from all major American institutions by serving as a vehicle for the white supremacy, fueling settler colonialism, racial capitalism, and their enduring legacies of oppression. American psychology and psychiatry have played a critical role in constructing the fictitious racial taxonomy of white supremacy and the biological notions of race necessary for executing the racist policies definitive to the American enterprise. So let's talk a little bit more about scientific racism. Physicians such as Dr. Samuel Morton exploited false sciences like craniotomy and phrenology to promote Black mental inferiority and physical superiority. These claims were made to justify slavery and its widespread human rights abuses. In the early 1900s, prominent psychologists like Sir Francis Galton, whom we'll see in the next slide, served as key architects of eugenics. He and his colleagues advanced this violent fiction of white supremacy, relying on IQ tests to draw false associations between geographic region and socially determined traits. This scientific racism was incredibly violent and dangerous. It sanctioned forced sterilization campaigns that violated tens of thousands of non-white, non-able-bodied, and neurotypical Americans. It also fueled the rise of Nazi Germany and the Holocaust and centuries of racist immigration policies. Measurement and quantification do not equal objectivity for a mental health profession seated in eugenics and white supremacy. Dr. Robert Guthrie's groundbreaking, Even the Rat Was White from 1972. I wonder if people have read this book or heard of it before. It should be required reading for all of us. And I think the fact that it isn't tells us something. I highly recommend it. It exposed both how deeply racism and white supremacy have been intertwined with American psychology and how ardently Black psychologists have fought to disentangle it. So to be clear, the concepts that I'm putting forth today are nothing new. They've been around for decades or even centuries. Dr. Guthrie contended that racist theories of Black mental inferiority recur with an appearance of enough newness to obscure the cobwebs of the past and actually encourage a repeat of the same defenses utilized decades ago. So this fiction of Black mental inferiority, whether it's tied to nasal septa, skull sizes, or IQ tests, reflects a perpetual cycle of indicting Black humanity and trying to prove Black mental inferiority. The common bond, what is it? It's white American psychologists' obsession with testing of Black people, as Guthrie says, whether it is their hair, their skin color, their nasal bridges, or their intelligence. So this publication was put out 50 years ago, and the messages still reverberate today. For a mental health profession seated in eugenics and white supremacy, measurement, assessment, and testing are racism until proven otherwise. So in psychiatry, we have a very long history, a centuries-long history of psychiatrists pathologizing Black people's emotional and adaptive responses to racial violence, rather than contextualizing their suffering and indicting the oppressive structures causing them harm. During slavery, we see that enslaved people who attempted to escape or resisted subjugation were further condemned with diagnoses of drapetomania or dysesthesia atopica. Whipping was the prescribed treatment. The 1840 US Census reported absolutely no mental illness among enslaved people. Then in 1895, after emancipation, silent superintendents like Dr. James Wood Babcock, whom we see pictured on the left, reported a surge of Black insane people. The argument was that slavery and its human rights abuses were protective against insanity among Black Americans. Dr. Benjamin Rush, father of American psychiatry, whose face adorned the seal of the American Psychiatric Association until 2015, pictured in the middle here, was actually an abolitionist. He also believed that Blackness was a form of leprosy called negritude that could be cured by becoming white. These claims and contentions were not just historical relics that were innocuous. During an outbreak of yellow fever in 1793, Rush posted a note in a Philadelphia newspaper informing Black people of their innate immunity to yellow fever that white people lacked. So clear example of biological racism. He implored Black people to care for their beleaguered white peers. Over 5,000 people perished during this deadly epidemic. Though Rush later retracted his statements, he continued to claim that Black people suffered from yellow fever less than white people. His views promoting Black imperviousness to illness and biological racial difference circulated in medical journals well into the 20th centuries. And we can see how these ideas persist today in these very racist beliefs that Black people are more immune to pain. Some of you may be familiar with the scholarship of Dr. Jonathan Metzl. He describes how during the civil rights movement of the 1960s, psychiatrists characterized angry, politically active Black men as suffering from a reactive psychosis, while attributing similar symptomatology in white people to neuroses. These egregious discriminatory practices endure today. For example, children of color continue to be overdiagnosed with disruptive disorders compared to their white peers, while their experiences of racial trauma, including police brutality and disproportionate punishment in school settings, are frequently disassociated from diagnosis and treatment. Organized mental health has indeed historically remained silent about racism and racial injustice. We don't talk about how psychiatry has advanced a narrative of Black criminality to justify war on drugs, political rhetoric, giving rise to mass incarceration and the overpolicing of Black communities. These two antipsychotic ads that we see from the 1970s on the left capture psychiatry's blatant anti-Black racism. The racism of these ads becomes even more prominent and troubling when we confront the white supremacy of the era captured in the state-sanctioned violence perpetrated against Black children, which we see on the right. Our practices, diagnostic and otherwise, are steeped in whiteness and normed to whiteness. This historiography is so rich and vast, and it really warrants a much deeper interrogation combined with a reckoning and reparative process. Dr. Kimberly Gordon Achebe has written an outstanding book chapter detailing the legacy of racism in American psychiatry and detailing many of the points here. The historical themes that we reviewed very briefly today provide scaffolding for universal anti-racist supervision that does the following: challenges biological constructions of race. It challenges pathologizing marginalized people's adaptive responses to racial violence and other forms of oppression. It interrogates measurement and assessment tools, claims to objectivity and neutrality. And it also indicts structural racism's assault on children and families, while challenging organized mental health silence about injustice by speaking up about it and challenging it. In April 2021, the Centers for Disease Control declared that racism is a serious public health threat and pledged to take specific actions to address this issue. This is not a new issue. It's an incredibly old and devastating one. History is crucial for not only helping us understand racism's deep origins in mental health, but also for understanding why racism is the enduring public health crisis of our time. As an example, oftentimes when we think about Black maternal mortality, we fail to connect it to the rape and horrors of American slavery. And when we consider Indigenous peoples' higher rates for suicide, we don't think about the mass graves of children from the boarding school era. Racism is so clearly the enduring public health crisis of our time, and history informs our understanding of it. This is another rich and vast scholarship, which I attempt to distill here, but really could do no justice to in a single slide. So we know many things about racism and its impact on health. People of color in the United States still experience higher rates of mortality, comorbidity, and impairment. Self-reported experiences of racial discrimination have been linked to countless health consequences, including the more rapid development of coronary heart disease and the birth of babies lower in weight. Discriminatory practices unrelated to healthcare, such as tough on crime policies, mass incarceration, and the detention, deportation, and over-policing of Black, Latinx, and undocumented people in community and school settings compound these inequities and permanently alter life trajectories from one generation to the next. Ideally, clinical care would treat racism's toxic health effects, or at least prevent it from entering the clinical encounter. However, we have ample evidence demonstrating how it functions as a conduit for pro-white implicit bias, whereby patient-provider interactions, diagnostic and treatment decisions, treatment adherence, and patient health outcomes are directly impacted. We know that white patients receive better quality of care than non-white patients, and clinicians in healthcare institutions routinely deny Black patients the services and interventions offered to white ones, regardless of socioeconomics or insurance. Existing strategies for addressing these inequities, including cultural competency and implicit bias training, have not done much to substantially change health disparities, many of which are either unchanged or getting worse. So one of the defensive narrative scripts that often plays out in healthcare settings to try to thwart anti-racist efforts is the idea that talking about racism and anti-racism is political and not health related, which is a distorted claim to make, as if not talking about racism is apolitical. Everything that we do is political. Given everything that we know about racism, all the research that we have, some of which we touched on in the previous slide, to not engage in anti-racism is an affront to the evidence base. It's a failure to uphold evidence-based care. It's also a failure to honor our oath to first do no harm. And it's a failure to uphold a clinical and moral imperative. No more remaining on the sidelines. This constitutes a violence. Let's move on to step 3. On March 23rd, 2020, 41-year-old Daniel Prude was asphyxiated when police used physical restraint on him. Earlier that day, he was seen at the University of Rochester's Strong Memorial Hospital. Psychiatrists discharged him home despite family members reporting several recent suicide attempts, like jumping headfirst down a flight of stairs and attempting to jump in front of a train. Medical students from the local White Coats for Black Lives chapter wrote an open letter condemning the University of Rochester and calling for it to end its relationship with the Rochester Police Department and ICE, and to reallocate funds from current public safety structures towards alternative non-carceral methods of ensuring safety on their school and hospital campuses. In striking contrast, the University of Rochester Medical Center said its care of Mr. Prude was, quote, medically appropriate and compassionate. How on earth could it be medically appropriate and compassionate if he ended up dead? We begin to see the distorted ways racism operates, our language, the architects of its harm. So why is this step of admitting to being racist so important? So even though we know racism is a public health emergency, a pivotal determinant of health inequities, there are a variety of defensive maneuvers that try to obfuscate its far-reaching impact. Denial is a key one, which we saw in that last example that I shared. In academic medical centers in particular, Providers' self-proclaimed oath to first do no harm and rhetoric of progressiveness can also conceal racism's pervasive influence on clinical care. Many of us who are doctors and healthcare providers believe that we are part of a noble profession. So to step back and look at the harm that we're doing can be very hard for people to do. We see some of this defensiveness, obfuscation, and denial persisting in the continued widespread use of race-based clinical algorithms and psychological and psychometric testing rooted in white supremacist ideology. How can we think back to the previous slide, or can we think back to the previous slide and the University of Rochester's denial of any complicity with the racism that ended Daniel Prude's life? We all have a role to play and all have responsibility to assume. So anti-racist supervision requires that supervisors acknowledge their complicity and surrender the typical claim of "I'm not a racist." Kendi's dichotomy of racist or anti-racist focuses on measurable actions and behaviors rather than static character traits. So this could reorient people away from defending their personhood against the accusation of being racist. Remember that anti-racism is a verb. Think of how you can engage in anti-racist activity each day. By admitting to being racist, we acknowledge that we do have choices that we can make each day, and those choices can either bolster the invisible forces designed to maintain the status quo, or they can dismantle and challenge them. Kendi will also say that individuals typically engage in both anti-racist and racist behaviors. He claims that racism is not who we are, but what we are doing in the moment. So these are some of the defenses that can come up to maintain the racist status quo, preserve silence, and prevent any meaningful dialogue and change. Emphasizing good intentions, remaining silent due to discomfort. These things are damaging, not only to supervisees' health and well-being, especially if they are trainees of color, but also to the clients that we're taking care of. These defensive maneuvers are also unscientific in the sense that they betray racism's centrality as the public health crisis of our time. By contrast, when we willingly uncover the racism shaping our actions and thinking, this indicates a clear motivation to enact the anti-racist action steps that follow. Let's move on to step 4, heightening one's own individual race and critical consciousness to prepare for challenging racism and its intersecting forms of oppression. Kyla Schuller's book, The Trouble with White Women, is an excellent example. I highly recommend it. Her book looks at the trouble with white feminism. She fully divulges and reflects on her whiteness throughout the book as part of her intellectual and anti-racist undertaking. So we know that conscious efforts to avoid racial discrimination and engage in slow thinking have the potential to thwart the more dominant fast thinking derived from stereotypes generated by media and education. We see psychologist Jennifer Eberhardt here. Her intervention, training the Oakland Police Department to pause and question the validity of police stops, resulted in a 43% decline in the number of stops involving Black drivers between 2016 and 2018. So we have some evidence that by pausing long enough to heighten race consciousness, supervisors can similarly identify and challenge their own biases and manifestations of white supremacy culture. But we have to be a little careful with this notion, or at least qualify it a bit more. Engaging in anti-racism and heightening our race and critical consciousness, these are not superficial or cursory attempts. This process of anti-racism is much deeper. It requires profound self-reflection. This is necessary for heightening race consciousness to engage in anti-racist supervision. So anti-racism, lifelong journey, deeply introspective work, unpacking and processing that the racism that lives and breathes within each of us is where we first start. And then we extend that to the people to our left and to our right. These two books here are excellent resources that I highly recommend. They provide a guided journey with very real, impactful, and practical exercises to help people take a look at their own whiteness, their internalized oppression, and to try to make shifts and changes in their beliefs and behavior. And then we can also think back to this idea of positionality, which came up at the beginning of the talk. So the positionality that I modeled, the self-disclosure that I offered to you all, is precisely the kind of disclosure that supervisors can think about formulating with the trainees that they're working with. It not only provides trainees with a measure of accountability, but it's also role modeling for them, how trainees can also reflect on their own positionality and how it influences the clinical care that they're providing. So just want to take a moment and pause and see if people have any thoughts they want to drop into the chat or anything that they would like to say. Or any reactions or feelings that are coming up.
I think, again, same thing, you know, you'll be preaching to the converted. The other ones who are going to read the books you recommend. The words, you know, white supremacy and critical race theory, and there's a long list. You will lose the people who actually we need to reach.
What's the alternative that you would recommend?
No idea. I know what, at least I've seen that all these things and all these good people who are willing to hear, they don't want to hear because of the way, the choice of words we are using.
Would anyone else like to offer their thoughts?
Is it the choice of words, or is it that people are still new to this idea and it causes some profound discomfort and aren't ready to do that yet? But perhaps they need to hear it at least run by for a start.
Again, I'm fine with 1, 2, 3 bites. I just feel that the people who actually need to change behaviors, all of us, right? We are all racist, but some of us do more than others, and how to reach them. At least that's my experience. The minute I mentioned the words, some of the words you have used and the authors, I have to worry that if I keep persisting, I will lose their friendship and love.
Do other people have thoughts to offer or feel the same way or feel differently?
I think it can be hard to have this conversation sometimes with folks, particularly when they're not receptive. But at the same time, I think if I don't know about like the language use and the lexicon that you use to convey the idea. If you can't use it and you're going around the issue by using, say, a different set of words or a different set of phrases, or you're just constructing it differently, in and of itself, by like constructing it differently, you're almost changing the level of importance in some ways. You might be by like using a different language than, I guess, by you're almost minimizing it potentially by like changing the way that you're defining it, I guess. You may be minimizing it. I wonder if that would happen, particularly for those folks who may not agree with it. You may find yourself changing, and I've had this happen. If you're having this discussion, you sometimes find yourself almost minimizing it then yourself by changing the language, and it loses the impact, or you lose maybe the underlying material that you're actually talking about because you've made it either overly simplified or not really maybe providing the same level of impact that you could have potentially. I mean, that's like been my experience when talking to someone who's maybe not receptive to the actual discussion.
I got a little. Can you guys hear me? Am I here?
Yes.
You know, I think that at least for me, as a white person, it can be kind of a scary arena to speak up about, because I don't want to say something wrong. But I think that especially the evidence that you've been laying out here today I mean, this is all real and a very, very big problem. I think that especially here in Idaho, there's a lot of denial about it having been a problem or still being a problem. And so that's just some of my thoughts.
Yeah, I appreciate what you both said. So just what you said, I think the way that I've conceptualized what you're describing is, am I engaging in white supremacy light? So, you know, I've had experience talking about this or teaching and lecturing about this for over 10 years. And so much of what we say or can say is tied to the zeitgeist of the era. And when I first started doing this work in 2012, literature on racial microaggressions was the big thing. And now if we kind of look at where we are 10 years later, you know, in the aftermath of COVID and George Floyd's lynching, it's quite different. But I know for myself in this work, and this was sort of an evolution, engaging in white supremacy light and softening things has felt like a stab to my soul. And so I generally don't do it because I think it's damaging not only to myself, but to people I take care of. At the same time, I think, I'm so sorry, I didn't catch your name, the other person who just spoke.
Scott, you listen.
Yeah, Scott, no, I think what you shared is quite right. And sort of the humility that you embodied of saying, I don't quite know what to say. I might say the wrong thing. Daryl Sue has actually written quite a bit about this, about the unique challenges that white people face in dialoguing about racism and the unique challenges that people of color face. I think most of us don't really expect perfection, but if there's an air of humility, effort, action, and trying, it can land in a way that's positive and impactful. And hopefully these action steps give people a starting place. People often do feel completely overwhelmed and almost frozen, as if they can't do anything or say anything. But hopefully these steps at least give one thing that people can do when they walk away today. I'm going to keep on going. I'm already behind on the slides, but truly I think the dialogue is far more impactful and takes us further. So we'll just do our best to get through this as best we can. Thank you so much. So I want to just move on to this next step, the fifth action step of cultivating foundational knowledge in order to detect racism as it occurs, and also to define the actions necessary to block this harm. So I think this step in particular reminds us that anti-racism is a daily, lifelong journey, one that relies upon self-examination and reflection, but it also is a cognitive intellectual effort that involves, you know, exploring and understanding various multidisciplinary literature, some of which I'll cover here. So maybe your anti-racist action or verb over the next few weeks is to find one of these books or one of these articles and read them. So these are the three arenas of foundational knowledge that I conceptualize. One pertains to identifying and then challenging racism using a multi-level framework. There's a growing literature about anti-racist clinical care. And then I mentioned some of Daryl Sue's work pertaining to meaningful racial dialogues and the unique challenges faced by people of color and white people. In the interest of time, I'm just going to walk us through the multi-level framework example. So this idea of identifying racism as a prerequisite for challenging it, this is a very established idea put forth by people like Dr. Kamara Jones, Dr. James Jones, and also Dr. Ibram Kendi. It also relies on Bronfenbrenner's ecological system theory, and it's helpful for thinking about how these various different forms of racism, micro and macro, collide during a clinical encounter, which we could say takes place on the interpersonal level from person to person. The other idea here is that racism is not in a vacuum and that it rests upon a foundation of whiteness and white supremacy. So obviously this is a very text-rich slide, which, you know, I generally don't like so much for presentations, but I also think that we have to acknowledge that this information is detailed, nuanced, sophisticated, and, you know, warrants deeper examination. But the idea here is that we have these different forms of racism operating on different levels. I'll give an example of racist ideology. This level is inspired by Ibram Kendi's book, Stamped from the Beginning, which looks at the history of racist ideologies in the United States to back up racist policies and practices. So one idea that comes to mind for this racist ideology is the idea of adultification. Adultification relates to adults viewing Black girls as less innocent and more adult-like than their white peers. There's established research relating to this. A corresponding ideology pertains to white innocence and vulnerability. This racist ideology is directly tied to slavery. It was the justifying narrative for abusing, exploiting, and torturing Black children as a part of American slavery. So what does this mean for clinical practice? So I'm just going to give you all a moment just to read this clinical example for yourself and just take a minute and try to think to yourself, what are the different forms of racism that are taking place here related to ideology, racist abuse on the interpersonal level? Just take a moment to read and reflect, and then we'll move on. I think one question to ask yourself is, how many of you have seen a clinical example like this? This is one that I've heard over and over again when I'm giving talks and presentations. Okay, we are going to take a look at whiteness, which I want to emphasize because it's so frequently left out of content pertaining to racism and anti-racism. And I think it's precisely for the reasons that we've been talking about, that people shut down when whiteness and white supremacy are brought up. But they're really crucial for us to think about in terms of anti-racism clinical care and supervision. So this article by Dr. Rhea Boyd, The Case for Desegregation, it's a 2-page, rich, wonderful article that covers whiteness and its related definitions. I'd highly recommend it. I just want to take a look at white hegemony as one example for this step. So white hegemony establishes and reinforces racial hierarchies in which white people nearly exclusively hold decision-making power. In the upper left corner, which pertains to white faculty, senior faculty, and departmental chairs, we see the overwhelming dominance of white leadership. We can also see the racism of the relatively flat lines capturing Black and Hispanic faculty and chairs over the past 40 years, which we see in the lower left and right corners, and also in the upper right corner with Asian faculty and departmental chairs. So it's just something to think about. It's a really helpful research paper, but then how do you take information like this and try to think about it in your daily practice? So maybe a question that you can ask yourself is, how does this show up in my clinical and supervisory work today? White hegemony manifests in all domains of organized psychiatry, as we see here. This is a picture of the executive committee of the APA Board of Trustees. Leadership like this sets the agenda for our profession and clinical guidelines and standard of care. I think we have to ask ourselves in 2022, is it racist or anti-racist to have an all-white leadership team? Is this a continuation of the legacy of white supremacy or a break from it? We also see this white hegemony looming over us in the long hallways covered with photos of white, older cishet men. These are the fathers of profession who look nothing like many of us, who not infrequently perpetuated deeply racist views towards our ancestors at best and committed human rights atrocities at worst. We can think of father of American psychiatrist Benjamin Rush as being a key example. So I'm going to move on to step 6, just so we can have a little bit of time to discuss at the end. This is the step of dismantling racism during supervision and clinical care. So I want to open it back up to the audience again. You all have done a great job of participating and engaging. In your opinion, what does dismantling racism during supervision and clinical care look like?
I've heard that it's important to put cultural and racial distinctions up on the table early on in supervision for conversation, because coming from different backgrounds, you're not going to understand well what things may mean to the other person. And so you need to be culturally humble to accept reflections.
Great, thank you. A question that's coming to mind, but feel free to offer whatever you like. I guess a question that came to mind for me was for residents, students, and trainees. On a daily, regular basis, do you feel like you're getting the training and supervision and support to learn how to talk about racism and white supremacy with the clients and families that you're working with?
I think one of the difficult things, at least in Boise, so I'm part of the Seattle track. So we did 2 years in Seattle and then moved to Boise. The difficult part is in Boise itself, like our patient populations at most the sites, I would say it skews like a large proportion are Caucasian, and they're not of any sort of ethnic background. And so for me, at least, one of the big shifts, at least in shifting to Boise and the training in Boise, is that the piece that like involves, say, a cultural competency or just understanding different backgrounds, it's somewhat lessened just because of the makeup of Idaho and the makeup of the populace here. And so I feel like when I have had patients from different cultural backgrounds, it has come up, and we've talked about how is that impacting treatment. In particular, patients who are maybe refugee status or other patients who are not part of the dominant majority within Idaho. It definitely comes up when we're talking about treatment. But I think one of the big problems, I don't want to say it's a problem, but it's just the nature of Idaho is that there's not that many, we don't have that much of a diverse population, although it's changing, year by year. I think one of the big questions or things that can come up during supervision is talking about how different types of cultural biases or even our own interpretation of what their culture is. So maybe we're projecting like what we believe is their culture, and we may not have any idea of actually like what is the actual cultural importance of their willingness to accept healthcare or even just other aspects. And I think having that discussion and just realizing that maybe you're missing something big in regards to the cultural identity of that patient, and just having that discussion, or at least starting it or attempting to start it, can be very meaningful.
Yeah, so listening to what you're saying and then also seeing Charles' comment about Idaho being 93% white, this raises this very important question or concern. Is anti-racism only for patients of color or trainees of color or supervisors of color? It also needs to apply to white people. And of course, here, I didn't focus on whiteness, which I think in the settings that you're describing, that dismantling and challenging whiteness would have to be a part of things. But it's really telling and also sort of speaks to white normativity and other forms of normativity that we sort of conceptualize this as being something that we're only doing with people of color. So I'm just going to move through our last few slides before we finish up. This conversation is great. So, these are just some thoughts that come up about, piercing this wall of silence and starting to talk about racism and whiteness, and maybe seeing some of the terms and definitions here to provide you with some tools, or even relying upon, there's so many great articles that are coming out. There's been an explosion of anti-racism content in biomedical journals over the past couple of years. So these are all ideas for thinking about things. You can even pull up the diagram, the multi-level framework, and try to think about how it's operating either in your supervision or in the clinical care. One thing I want to close with is sometimes we focus on seeking definitive answers from reductive frameworks, and a shift that is really conducive to anti-racism is to ask better questions. So for each of these steps that I've covered, there's a series of reflective questions that people can ask themselves on a daily basis. One example is, how are the primary clinical interventions and guidelines you use today developed? For whom were they created and normed towards? What was the positionality of the individuals who created these tools? Did they have a racist or an anti-racist agenda? Okay, so just circling back to our objectives that we had at the beginning of this talk, hopefully you are walking away with at least one reason why an anti-racist approach for supervision is different from a not racist one. Hopefully you can list a couple of action steps that go into an anti-racist supervision practice, and maybe make one statement about your own positionality as a supervisor. And I think, the biggest thing is to walk away knowing that anti-racism is a verb. There's something that you can do each way to think about racism and whiteness and to try to dismantle it. And you did that today with your conversation and dialogue. I want to close with these just beautiful resonant words from Indian author and activist Arundhati Roy. She describes how the COVID pandemic serves as a portal, one that forces us to break with the past and imagine the world anew. Either we choose to walk through it, dragging the carcasses of our prejudice and hatred, our dead ideas, or we can walk through it lightly, ready to imagine and fight for another world. And I think this imaginative spirit has to be fueling our anti-racism work. So instead of working with the old, we reimagine things that we never would have thought possible in our profession. Some other ideas for immediate action steps. These are some of the papers and content that I've been involved with that have recently come out. One about anti-racism and child mental health. And then my colleagues and I recently wrote a paper about an abolitionist approach to anti-racist medical education. It talks about the anti-racism modules and curriculum that we created and are piloting at medical schools and conferences nationwide. And as always, I close with some better questions that we can ask ourselves instead of summative points. I hope you can continue to ask yourself better questions. And as always, if you'd like to be in touch, this is my email address and my Twitter account. Thank you so much for your participation. I really appreciate it.